Hello and welcome to EHJ Today. My name is Stefano Taddei and I am International Associate Editor of the European Heart Journal. We are speaking from Barcelona. There is the annual meeting of the European Society of Cardiology. And it's my privilege to introduce you Professor Perry Elliott and Professor William McKenna, both from UCL London, and we will discuss the new release of guideline on in hypertrophic cardiomyopathy. So, Perry, please introduce us to the new guidelines, the novelty, and the specific new aspect of guideline for this important clinical condition.
Okay, thank you. So we're very proud this year to launch the first guideline on hypertrophic cardiomyopathy for 10 years. The theme, I think, that runs through the entire document is individualized care. And what we've tried to do in the pathway from diagnosis through to treatment is to provide clinicians of all kinds, general practitioners, cardiologists and specialists within tertiary centres, with practical guidelines for the diagnosis and management of this complex family of diseases. We believe that we've innovated in a number of key areas, and perhaps the headline is that of sudden cardiac death, where we've provided a tool for individualizing risk. But we've also tried to help in other areas, and in particular in relation to women with hypertrophic cardiomyopathy. And we've provided specific advice on reproduction, contraception and so on.
Okay, and what about, especially because you thought it's a big family, and what's new, probably in genetic predisposition, and another concept that to me is important, especially for physical activity and sport medicine, because it's considered one of the causes of sudden death that is very harmful for people.
Yeah, I think your first question is very important, because one of the biggest changes that have happened in the past 10 years has been an explosion in our knowledge of the genetic basis of this group of diseases, and we very strongly believe as a task force that obtaining a specific diagnosis critically affects the advice you give to a family, and we believe over the next 10 years will fundamentally change the way in which you treat individuals affected by this condition. Second point on exercise is obviously very important, and we have addressed that in the section on prevention of sudden cardiac death, but we haven't dedicated a huge amount of the guideline to that, as that's being covered by other ESC documents.
And there is any significant novelty in treatment?
I think we have the same drugs as we had 10 years ago. We have operative and other interventions for treating outflow tract obstruction. But I think the key innovation here is that we're not into a debate about comparing one therapy with another. What we want to do is people to pick the right therapy for the right patient. So the innovation, I think, is in the selection of patients for specific therapies.
Okay. So, William, what is your opinion about the real advancement of guidelines and the treatment and the clinical application of?
Well, I think Perry's mentioned. So the fact that it's individualized, it's a much more individualized approach in relation to diagnosis, in relation to risk and management. And if you take the risk assessment, historically we've known that if your brother has died suddenly, or if you've got non-sustained VT on a tape recorder, or you fainted, these are adverse risk, and they give you a relative risk. It means that your risk of dying, if you have that versus not having it, may be threefold or fivefold more. It doesn't give you an absolute risk. And a major change in the guidelines over what we and the joint American guidelines had done and what the current American guidelines have is actually the calculation of an absolute risk. And here you plug in the age, the hypertrophy status, the outflow tract gradient, left atrial dimension, syncope, non-sustained VT, and the family background, and you get a 5-year calculated sudden death risk. And that is a real difference. When you're dealing with a patient, you're not lumping a whole bunch of patients who are very different. In the past, if you had somebody who had non-sustained VT, it's completely different if he's 15 versus 50. Here, in the absolute risk, individualized with a risk calculator available to you, we're giving an absolute risk. And one of the questions I'd throw actually back at Perry is, in guidelines, you try and have cutoffs that you would put an ICD in the following circumstances, and I don't think it's quite as absolute as that in the guidelines, but there is a calculation of risk with the implication that you would give serious consideration to a defibrillator if I think the cutoff is more than 6% per year. And I would ask you to expand on that, particularly from the view that if you're 60 years old, a 1.2% sudden death risk may be acceptable. If you're 16 years old, a 1.2% sudden death risk is not acceptable. And how would you rationalize that within the guidelines and the recommendations?
Yeah, I think that's a very important point, and I think one of the things we address overtly in the text, and perhaps for the first time in a guideline, is that we recognize that there is no accepted definition of a risk that justifies intervention. I think when we look at guidelines for coronary disease, for heart failure, the recommendations are based on trials and the characteristics of very specific populations. But you say my idea of risk is different to your idea of risk, is different to the patient's idea of risk.
Sure. I mean, I may go bungee jumping and free fall out of an airplane, and you may not even wish to fly in an airplane.
So I think we've recognized that in the guideline and in the recommendations. So we've provided some indicative cutoffs, but the only class 1 indication we've given is for someone that's actually had a cardiac arrest. And we've retained flexibility, and what we want people to do is to calculate the risk and use the tool to explain that risk to the patient, and then have an intelligent conversation about what between the physician and the patient seems to be an appropriate threshold for intervention. Balancing the adverse effect of the ICD on psychosocial well-being, their economic well-being, and so on.
Another area of you asked about the strengths of the guidelines, and historically we've sort of had a standard definition of hypertrophic cardiomyopathy, and yet within that essentially unexplained hypertrophy, there are sarcomeric disease, there's storage diseases, there's mitochondrial disease, there's other syndromic diseases and other inherited conditions. And I think my view, without going into detail, is that the guidelines actually create a scenario of considering red flags for these various other conditions which have a different prognosis and different outcomes and different natural history, and I think that's an important recognition within these guidelines. I don't know what you think, but I think it's a strength.
I agree,
if I add something, in your opinion, there are more guidelines or textbook or updated textbook? Because usually we expect from guideline you have to do this one, you have to do this one, you have to do this one. What are you telling this? Just really updated review of literature, the opinion of expert, but at the end you have to discuss with the patients and to take a decision in base of the risk. So, Perry, is more guidelines or just more textbooks?
So I know there are people out there that want to be told what to do. And guidelines are often used in that way, but there's a clue in the name. This is a guideline. So this is meant to be a tool to help physicians in difficult scenarios. The point that Bill raised about diagnosis, we do list in a very textbook kind of way rare diseases, but many of these diseases are rare because no one looks for them. So it's all too easy as a cardiologist to perform an echocardiogram and say the patient's heart is thick, and the process of diagnosis stops at that point. So what we're trying to do is to take them by the hand and say, you need to think a little bit more, and you need to use the tools that you have available. There's nothing fancy in this. We're not saying that you have to do fancy genetic tests, but we believe that if you use what one of our colleagues on the task force calls a cardiomyopathy mindset, if you use simple history taking, assess a family history, you look at the ECG and the echocardiogram through a different prism, then you make these diagnoses. But you don't have to encapsulate that in a single "you must do." what we want to do is people to appreciate that this is not a single disease but a family of diseases.
That's important. So we are going to finish, and please, Perry and William, just a brief statement what people have to take home a message about hypertrophic cardiomyopathy.
You want me to go first?
William first.
Well, I think your question about textbook versus guidelines, I think and Perry's answer, mindset, I think it's coming at a patient with hypertrophic cardiomyopathy or possible hypertrophic cardiomyopathy with a slightly different and broader mindset. Is this what it appears to be? If not, what else could it be? Are there signals in the family? Are there funny markers related to the electrocardiogram? Are there red flags we should be thinking about? And then the conventional sort of, when you think about when a normal cardiologist thinks about hypertrophic cardiomyopathy, it's do I put in an ICD and can I do a myectomy or reduce the gradient with some procedure? And I think a strength of the guidelines, which was your question, is that most patients with hypertrophic cardiomyopathy don't need a defibrillator and they don't need a septal reduction procedure. But they do need consideration, am I at risk of atrial fibrillation? Am I at risk of embolic stroke? Am I graduating from being a dynamic to an impaired ventricle? Do I need, what is the prognosis in relation to heart failure related complications? And I think the guidelines acknowledge this. Now, clearly we don't have magic to treat heart failure in hypertrophic cardiomyopathy, but at least recognizing that it's, when you're 60 years old and you've had the disease for 40 years, it's probably still not a dynamic aggressive ventricle that needs a high dose of a negative inotrope. There's a gradual evolution of disease, which in part of the new mindset for cardiologists to recognize as part of the spectrum of disease. And the guidelines attempt to raise awareness about this and give some guideline around management and how the evolution should take place.
Okay, this is a wonderful conclusion for our interview. Thank you very much.